we're going to talk today about managing acute GI bleeding, both upper GI bleeding, lower GI bleeding, and the different ways we break things down to help you all think about academically what you're supposed to do. But then obviously part of this is we are in a new academic year, so we have fresh new out of med school all-stars joining us. So just sort of what happens logistically on the floor in the ICUs and what you should be focused on as you take care of these patients and help us take care of these patients as well. So main talking goals for today, identifying key parts of the history, physical, that help us get an idea of how we're going to localize bleeding, reviewing acute management of GI bleeders from the first second you see them to their first 24 hours to 72 hours in the hospital, which are usually the most important time periods. How we build our differential, which in the acute management is less important because a lot of the testing is sort of the same. But we want to have an idea of what do we expect to find while we're testing these patients, and then long term, what was the root cause of their bleeding, so we can hopefully never let it happen again if at all possible. And then as an internal medicine doctor, as the sort of quarterback, the captain of a patient's care here in the hospital, like you guys are the main people for these. You're their point person. You're the one coordinating all this and taking care of them. Who's involved in that, right? Who are you activating? Who are you getting onto the team? How are you managing all those different pieces, especially when those pieces maybe aren't talking as well as they should to one another, which we should be better about as well. But you having a sense of who all's involved, even if some of those discussions happen around you at times, which isn't the way it should get done, but being more aware of what's happening with these patients will help you feel more comfortable taking care of them. So some key definitions just to start very simply. Upper GI bleeding is actually a much smaller portion of the GI tract than lower GI bleeding, and we often actually break down lower GI bleeding more. But upper GI bleeding is anything proximal to the ligament of Treitz. So if you're bleeding in your esophagus, your stomach, and your duodenum, that's upper GI bleeding. Everything else is lower GI bleeding. We usually differentiate we break down lower GI bleeding a little bit more into small bowel versus colonic in origin. But by definition, upper GI bleeding is anything proximal to the ligament of Treitz. A quick review of some of the anatomy that I'm going to talk to that I'll breeze through a little bit more quickly, and it helps to have at least helps me to have a bit of a visualization. But especially when we talk about the upper GI tract, upper GI bleeding, there are some big blood vessels, right, coming off the celiac artery that feed to the major organs of the upper GI tract. So the stomach, the first portion of the small intestines, the duodenum, also feeding part of our liver, our pancreas as well. And so knowing some of these vessels, or at least being an idea, so what these diagrams are meant to show you, right, is sort of the big blood vessel that courses right by the pylorus in the first portion of the duodenum called the bulb. That gastroduodenal artery is a big blood vessel that might come up a lot when people bleed and they eventually end up with an angiogram that gets embolized. You might hear that the IR doctors took down this vessel. Similarly, their left gastric, the right gastric, which feeds the lesser curvature here, as opposed to the short gastrics and the splenic artery, which goes behind, which then branches off into your left gastroomental and your right gastroomental. So getting a sense of, in the heat of the moment when someone's bleeding, you're not going to be sitting there saying, based on my physical exam, I think this is a left gastric artery bleed. Maybe you have that skill. I don't have that skill. But the main takeaway, though, is that knowing the general idea of what parts of the stomach are being provided by which arteries, when we go in and we find an ulcer, for example, and we treat that ulcer, it helps my radiology colleagues understand, okay, you are going to do an angiogram, which hopefully will show you the results, but let me tell you where in the anatomy I found the lesion, so you know where to really focus your eye when you're looking for that contrast slipping out of a blood vessel into the GI tract. Okay. The other takeaway from the blood flow pictures here is to get an idea of how vascular, especially parts of the upper GI tract are, but the stomach especially. And that'll factor into some of our differential diagnoses later on. But what I mean by that is that it's really hard for our stomach to get ischemic in many parts of it because there's so much redundant blood flow. And also when we need to cauterize, embolize big vessels, we know that there's so many other small vessels branching off of these bigger ones that even if I have to take out part of the left gastric, the likelihood that the rest of the stomach will be able to sort of fill in the gaps from these other vessels is a lot higher than it is in other parts of the bowel. And so we think about that, especially in the colon. You guys are all taught in medical school about the watershed areas, right? Where you started to get into those areas where the blood distribution of the SMA is transitioning into the IMA, and where the IMA is transitioning into the systemic circulation that feeds the rectum. That would be examples of areas where there's less blood flow, where now if all of a sudden you're embolizing things, you're treating things, and you're decreasing blood flow further, you might create more problems down the road. Over here, we don't have to focus too much down here on the bottom left, but again, general anatomy of the stomach, because a lot of the peptic ulcer diseases and that we'll talk about today during the lecture, we're going to talk about certain areas. So knowing that the cardia is focused right around the gastroesophageal junction versus the fundus is this back portion of the greater curvature of the stomach, which feeds into your body, then turns into antrum. And then the pylorus here is that muscular sphincter that separates the stomach from the duodenum, and so on. So again, just familiarity with some of the anatomic terms that I'll be using throughout the talk. Similarly, moving into the second part, the last part of the upper GI tract, but you have the C loop of your duodenum here. So you have your bowl, first portion, second portion, third portion, fourth portion ending at the ligament of Treitz. And again, just getting a sense of some of these big blood vessels that happen to course around some of these areas. Really, the main one to focus on here is the gastroduodenal artery, which can get us in a lot of trouble. So starting with our first case, and then we'll talk through it together. But we have a 52-year-old Asian male, history of hypertension, hyperlipidemia, prediabetes, osteoarthritis, coming to the ER complaining of weakness, fatigue, and dizziness for the last 24 hours. Initially thought this was related to taking his antihypertensives, so he stopped taking them yesterday, but his symptoms persisted. On review of systems, he notes epigastric pain that may get worse with eating, and noticed that he's had 5 or 6 black tarry bowel movements over 24 hours. He last saw his primary care doctor about 5 months ago and reportedly had normal labs. Medications include lisinopril, HCTZ, atorvastatin, aspirin, ibuprofen every 8 hours as needed for knee pain, and metformin. So in this little case summary, which is meant to be as subtle as a hammer, if that's the saying, but what are the things that jump out at us that say what's going on with this patient who is tired, right? Fatigue, weakness, fatigue, dizziness. We don't have any vital signs, we don't have any other findings, but are there things that jump out here that say what's going on already? And so part of them, we have black tarry stool, so blood up higher up in the GI tract as its process as it moves through the body can turn that more dark black color, and then the consistency changes to what we describe as tarry and what is ultimately described as melena. So melena truly is that combination of not just the color, but this consistency of this gooey, you described it almost as looking hot. Though obviously we don't have you check it with a thermometer and touch it for temperature, but different than just hard dark stool, different than green stool. So this could be suggestive that maybe this fatigue is due to something like anemia, right? So there's evidence of possibly overt GI bleeding. History-wise, what jumps out at you as possible risk factors for bleeding? Well, he's on an aspirin for heart health because he's a male with hypertension, hyperlipidemia. Maybe that's primary prophylaxis. He might be taking some amount of ibuprofen for this osteoarthritis. In the stem, we didn't get much of a history of how often he's taking it. Lesser degrees here. There are certain ethnicities where rates of certain infections might be higher, which can be risk factors for GI bleeding. So here on this slide, I highlighted a couple of things that just in first pass would say to myself, maybe I'm dealing with an upper GI bleed, maybe even an ulcer as I make my differential. But again, the differential diagnosis of what's bleeding, less important in the acute management right now, because I got to figure out how sick is this person, right? Are they bleeding a lot? Are they bleeding a little? They already are symptomatic, but let's see what the next step is. So we examine them. They're a little tachycardic, even off their antihypertensive medicines, where they are baseline hypertensive. They are normotensive / maybe even slightly hypotensive based off the systolic number, but normotensive. But they have positive orthostatics. Their heart rate jumps up when they try to stand up, and we check their vitals again. There's mucosal and conjunctival pallor, and then the rectal exam here shows this dark tarry stool mixed in with some brown stool consistent for melena. So labs, some workup that was already started maybe by the ER. BUN is markedly elevated at 52 with a normal creatinine. Hemoglobin was 8. You'll remember from the STEM, they told us the baseline labs were normal. We found out that his hemoglobin was 14. Normal liver enzymes, normal platelets. So now, summing this gentleman up, you have a 52-year-old person with acute symptomatic anemia with evidence of overt GI bleeding, specifically melena. And so what does that melena tell us? So the differential here is we think he's bleeding. We have evidence that there might be some amount of blood in the stool, which is why the stool changed colors. Melena has a likelihood ratio of 25 for identifying an upper GI bleed compared to a lower GI bleed. So most melena probably is happening starting proximal to the ligament of Treitz, but not all melena. Here on this slide, it's not meant for us to read through every single one because I told you the differential diagnosis here is a little bit less pressing in the acute management. It goes to show you that things that can cause upper GI bleeding range from ulcers, varices, and throughout the list there. Lower GI bleeding can still cause dark tarry stool, especially right-sided colonic bleeding or small bowel bleeding for that matter. Here again, diverticulosis, right-sided diverticular bleeding can atypically present as melena. That being said, many of the things, especially colonic sources of bleeding, we expect to see more bright red blood per rectum, which this patient doesn't have. So based on this diagnosis and using both 2012 data and more recently, additions from 2021 guidelines that Dr. Lane from Yale released, but many of the recommendations, they didn't update all of them. So I used the 2012 ones as the basis, and then I'll add in the 2021 highlights. We are going to identify this person, since they don't have a risk factor for liver disease as far as we know. They had normal liver enzymes, no history that tells us otherwise, as a non-VARICEAL upper GI bleed. And so the guidelines that drive a lot of the management, again, the landmark group that came with was 2012. There was an additional update now in 2021. They wanted us to address a couple main areas. How do we triage and diagnose these people? What do we do before we decide endoscopy is needed? What do we do during the endoscopy? And what do we do after? So triage and diagnosis, this is especially important for you all since you're the first ones that see many of these patients, right? Like by the time the GI fellow or myself are involved, they might have been in the hospital for quite some time. So some of the guidelines, as you'll be familiar with other guidelines, are very simple, some of the recommendations. So it seems silly to say vital signs are important, but they are. And so that's going to tell us, that's going to set the whole timeline for if and when all the other stuff can happen, right? So a hypotensive tachycardic patient, they might need upper endoscopy, they might need surgery, but we got to make them less hypotensive and less tachycardic before we can get there. In general, this was both in the 2012 data and further reasserted more confidently in 2021, but that in general, we want to use a restrictive transfusion system or protocol whenever possible. And really the caveat being active coronary artery disease, where we would target a higher number, but transfusing for a hemoglobin of less than 7 is very much the goal. And that's been, again, I think our ICU team here does a really great job educating you all on that in general, and then also practicing that. But GI literature was slower to pick up on that. So in 2012, they were like, yeah, restrictive, but think about using 8, think about using 10. In 2021, they said restrictive transfusions, hemoglobin of 7, except in like very specific acute ACS in addition to GI bleeding, active large volume hemorrhage where you're not sure that the hemoglobin actually reflects the current state of the patient, right? So if a patient opens up in front of you and is having melena, hematemesis, and then starts having bright red blood, yes, their hemoglobin was 8 on the last check, but you're now worried that they lost multiple units of blood. You're not going to wait to recheck it and give them a unit of blood. So it still allows you to assess the situation, but again, restrictive, less blood transfusions better because of the negative effects of blood transfusions that can be seen in terms of just transfusion reactions, excess volume to the patient, and so on. And then also long-term issues with them getting more blood in the future if they need it. where does the patient go? So that's as funny as that is, as weird as it is to say, like what bed, like you're in a hospital, as you all are learning for our interns, not every bed in this hospital is equal in the sense of what can be done for those patients in that unit, whether it's nursing requirements, technology available, in terms of monitoring, and then in the cases where someone's sick enough where something needs to be done at the bedside, access for us to be able to do something at the bedside. So is this person a ICU type level sick, hypotensive tachycardic, not responding very well to initial resuscitation measures, active hemorrhage in front of us? Are they mild anemia, but have enough risk factors where they're not safe enough to go home and follow up as an outpatient? So but they're hemodynamically stable, but probably need to have their workup done on the inpatient side. Those patients probably can go to a medical floor, right? And so they developed scores that try to help us do that. One of which requires actual endoscopy pictures. So it's more of a prognostic tool after the full workup is done, including endoscopy, which is the ROCKALL risk score, which is on the left-hand side of the slide here. And then there's the GBS score, which is meant to be done in the absence of endoscopic evaluation. So really on first contact with the patient in an ER or in a medical floor setting where we can get simple lab values like a BUN, a hemoglobin, depending on the gender, some basic vital signs like blood pressure, their pulse, and then a few components of their history, right? And so the GBS score in both the 2012 guidelines and then reasserted in 2021 was meant to be to allow you as a medical doctor, or allow me as a gastroenterologist or any doctor to be like, someone's coming in, they had some bright red blood, or even they had a dark stool, we don't know what it is, but they don't have any of these risk factors, right? So their BUN is low. So when you have an upper GI bleed, the processing of the blood and the digestion of the blood can cause excess BUN to be in the serum, even though the kidney function is normal or stable. And so you can get this dissociation between the normal creatinine and elevated BUN. And so the higher the BUN, the more suspicious you are that there might be upper GI bleeding going on. Upper GI bleeding tends to be more dangerous in the sense that it can pick up more quickly and the patient will have less time to react to it. So if we are at a higher suspicion for an upper GI bleed, they get more points. The more points you score in the GBS score, the more likely you need to be evaluated in the hospital, and the more likely you need to be evaluated sooner than later. Similarly, if you don't have anemia, right, your hemoglobin is above 13 or 12, is different than if your hemoglobin is less than 10. Blood pressure higher / normal, better than if blood pressure is low. Pulse high, actually reporting or documenting melena on exam gets you points. And the takeaway from the GBS score is not necessarily how high can you score on it, but like golf, how low can you score? So someone who scores 0 or a 1 on all these categories, so no BUN, no uremia, normal hemoglobin, normotensive, and none of these down here, or maybe just one of them, like a mild tachycardia, they can potentially be discharged from the ER and go home. Because again, the studies have shown that this score predicts the likelihood of upper GI bleeding that may need intervention, more likely to progress if not treated. Anything above 1 though, the patient needs to be evaluated here. There are some studies that have looked at, is there a difference between someone who scores 8 and someone who scores 15 on this scale? And the answer is probably yes, but for main takeaways for today, the 0 and 1, consider maybe sending them home unless there's a good other factor that the GBS doesn't take into consideration. For example, if they're on blood thinners and you're going to need to watch them to make sure that their bleeding doesn't pick up, that this imperfect prognostic tool does not predict for that. So there's still some clinical judgment there. But a 0 or a 1, potentially outpatient. Anything above 1, inpatient, and where they ultimately get done depends on other things, other parts of their history and how sick they are. So let's say our patient here who had melena on exam was slightly below the blood pressure goal there, or got himself at least a couple points for blood pressure, definitely got some points for his hemoglobin as well as his heart rate. He needs to be evaluated. And now the question is, how do we evaluate them? And that's where getting the GI team involved is the main tool for diagnosing, especially mostly diagnosing and sometimes treating, is endoscopy. And before we decide if endoscopy is necessary, once we decide endoscopy is necessary, there's a couple things we can do ahead of time to improve the odds that our endoscopy will be successful. So in 2012, it was recommended that using IV erythromycin in patients with non-variceal upper GI bleeding could be considered. In 2021, the update said they strengthened that recommendation, even though the evidence is still weak. I'll tell you that the evidence being weak is mostly that they never studied it to improve outcomes like less transfusions, death. What the outcomes they looked at, though, was like, do we get good pictures? And do the patients need more endoscopies? And so sometimes when you go in and there's a stomach full of blood and clot, you pull the scope out and you can't do anything. So that person now needs to be resuscitated, given more time, and have another set of sedation for us to take another look. Erythromycin helps decrease the odds that that's going to happen. And so we get a better look. We're able to do a complete exam, which may ultimately lead to more diagnoses, potentially more treatment, and less endoscopies overall during the hospital stay. But because, again, it was never studied as improving outcomes, right, including death, the transfusions, the data is still limited. However, a one-time dose of IV erythromycin, 250 milligrams, 30 to 60 minutes before, in the 2021 guidelines, is strongly recommended so that we can, again, optimize endoscopy once we decide to do it. The one place 2012 and 2021 separated is they actually kind of backpedaled a little bit on how strongly they feel about PPIs being started. And the recommendation was they couldn't strongly suggest that it's mandatory. That being said, the downside, the data quoted in the 2012 guidelines, and what we know is that starting PPIs seems to downstage the lesions we find on endoscopy. So if you have a bleeding ulcer and you start a PPI, even in those first 6 to 12 hours, by the time we put the scope in, we're more likely to find an ulcer already in the state of healing and less likely to be bleeding than if we didn't start the PPI. That's what we ultimately want to have happen. Endoscopy is sort of an adjuvant to the healing powers of the PPI and peptic ulcer disease. So if we can start healing early, it makes sense to start it. They don't have strong recommendations in 2021 on whether or not it needs to be IV versus drip. Past guidelines have been very much about drips, 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 and most of the other parts of medicine, pharmacists, ICU doctors, medicine doctors have been much more embracing the idea that the IV boluses are just as effective, so 40 BID. And clinically, that's what most of us will use. So the guidelines kind of backpedaled a little bit here, I think in part to step away from the drip versus bolus controversies, so to speak. But the idea being starting in a PPI, even if you're not sure that this is an ulcer disease, is a very, very low risk and potentially high benefit to the patient. So starting them on an IV PPI at the initial diagnosis or initial thought that they're having an upper GI bleed is reasonable. Noting the limitations of what a PPI can do, which is mostly downstage ulcers, but not necessarily change mortality. Is there benefit to lavaging in the new guidelines? It's not even mentioned anywhere. In older guidelines, there were thoughts. So it does, just as an aside, it doesn't help you when it's negative, and it doesn't change what we had to do anyway when it's positive. So in the medical world, as you all have learned, that's usually probably something we don't have to do, right? Like if it's not going to change your treatment, should it be needed? That being said, they've even looked at lavage to see if it's as a form of treatment, like we flush stomachs with ice water, we flushed stomachs with other solutions to see if it would help stop bleeding. None of that panned out either. That being said, at times will you still be asked, like, do they have an NG tube? Did you lavage it? What's coming out of the G tube and so on? Probably. But ultimately, all the other things we've been talking about have already decided which patients are on the road towards endoscopy and which aren't. So in general, it's not necessarily something that should be done very frequently, if at all. So when do we scope these patients? We had a question stem here of a patient who sounds like they're having a GI bleed. Urgency is important, and why we break these bleeders down into so many different categories is what is urgent for one person is not urgent for another. So for non-variceal upper GI bleeding, urgent and emergent endoscopy is within 24 hours. And so some studies have even looked at like spacing that out to as far as 48 hours, and others using that GVS score that we talked about and saying, okay, fine, we know 0 and 1s can go home, but is there some GBS score where it might make sense to prioritize their endoscopic evaluation? And there have been low quality subgroup analysis as well as data from Georgetown that we published that was retrospective data, so it's not a randomized control trial, but the data, there seemed to be a pretty good distinction between a score of 12 telling us that maybe these are the GI bleeders where they're sicker, they might benefit from going in sooner if something's bleeding and stopping it than others. But this is, again, lower quality of evidence because it's not the highest level that we want, which would be a randomized controlled trial to look at these things. But again, just getting a sense of 12 to 24 is emergent in the world of non-variceal upper GI bleeding, as opposed to variceal bleeding, as opposed to lower GI bleeding, which we'll talk about some of those different numbers. What are the benefits of looking earlier? So sometimes there are things that are not going to stop bleeding, even with a PPI, right? So the sooner we look, one would think, the sooner we stop the bleeding, less transfusions, less time in the hospital, all good outcomes. Studies have fluctuated on whether or not that's the case. Some people argue do endoscopy earlier because if you ultimately find really low risk things like a clean based ulcer, which we'll talk about, I could discharge that person the same day. And the studies have shown that most patients don't get discharged any faster, even if their endoscopies are pushed up. And studies have shown on the other end that pushing endoscopy too fast and too soon has negative outcomes in the patients because often we're sacrificing resuscitation time, which is really the most important thing. It's why it's the ABCs are first always, right? So if we're not resuscitating the patients up and catching up with the losses, even if they're still actively bleeding, them getting sedated and getting procedures leads to potentially worse outcomes as well. So that's why it's not as simple as they're bleeding, put the camera in right now. We want to find that sweet spot where they're fully as resuscitated as they can be and intervening early in the people who need to be intervened early on, but not sacrificing good volume resuscitation in our patients. Just so again, lingo-wise for you all when talking with the fellows or just as you're reading and you're studying and you're taking care of these patients, not all endoscopy is the same, right? So our standard upper endoscope looks at the esophagus, the stomach, and the first portion of the small intestines. That's your EGD, esophageal gastroduodenoscopy. A push enteroscopy, we're actually using a longer scope or even sometimes a pediatric colonoscope just to go as far as the scope will take us, usually into the middle parts of the jejunum. But there's no landmarks after you get past the ampulla until you get to the ileocecal valve. So everything will look the same in the small intestine. So that's just a rough estimation, but you're dealing with at least 50 to 60 more centimeters of scope to be able to push gently into the small intestines as compared to the standard EGD. Deep enteroscopy is or device-assisted enteroscopy is a category where we can theoretically get all the way through the small intestines from the mouth or from below, or in combination of the two. So this usually either has some sort of apparatus around the scope that allows you to sort of hold onto the small intestines and pull it over the scope. Not that many people have curtain rods maybe in their apartments anymore, but that's the visual you get where you kind of scrunch up that material at the end of the curtain rod and then your scope can go forward and then you scrunch everything back. And so you're sort of bringing the intestines to you as you simultaneously go deeper. So every patient is different with that. And so like I said, for antegrade device assisted, so where you put the scope in through the mouth, in some patients with the right anatomy and the right endoscopist, you can get into their colon from above. It takes a very long time. This is not like the 20-minute upper endoscopy, the 20-minute colonoscopy. These are hour-long procedures. We typically get less far retrograde when we have to go in from below just because of the anatomic and the embryological nature of the colon. We know some of that is retroperitoneal, some of that is abdominal, so there's a lot less flexibility of what we can pull over the scope. But again, theoretically, one could get from the colon to the pylorus with a device-assisted scope. But again, these happen over the scale of hours, and this is often when we're looking for bleeding in the small intestines. Before we go to those very labor-intensive, very long procedures, usually we use something like a non-invasive test, like a video capsule endoscopy, to have a target, right? Is it closer to the stomach than it is to the colon? Get some sort of estimation of where it's best to look from. So in our patient, we decided they needed an endoscopy. We resuscitated them with normal saline or lactated ringers because their hemoglobin was above 7 and it stayed right around that 8 number. We made sure we saw some improvements in their heart rate and in their blood pressure. They were feeling better with the extra volume added in, and we decided if they needed an endoscopy. And so this person is going to have peptic ulcer disease, their major risk factor being that they were on 2 different forms of an NSAID. They may or may not be affected with H. pylori, which we'll talk in a second. So when we put the scope in, what we're looking for here is what state is the ulcer in? So eyes on the left-hand side of the screen, a clean-based ulcer, and this kind of ulcer where there's not a raised portion of it, are very, very low risk for bleeding, which is what some of the data over here on the right side of this slide shows you. So for these lesions, we don't have to do anything else other than identify what their risk factors were for making the ulcers and try to prevent it in the future. Heal it with a PPI, get them off any unnecessary NSAIDs. If they have H. pylori, treat it. We biopsy these because sometimes malignancy can present as an ulcer. There is some more classic malignant appearing ulcers than others, but everyone's been surprised. And depending on the size and the biopsy results, we might bring them back in a couple months to make sure this heals up completely, because peptic ulcers will do that. Cancer ulcers might heal up partially, but there'll be some residual ulcer that even though your initial biopsies were negative, when you bring them back and it's non-healing, you check it again and now it actually was cancer all along. So ulcers over 1 centimeter in size in the stomach need to be brought back in 12 weeks after PPI therapy, even with negative biopsies for that reason. These other lesions here on an ulcer, so one where the clot's actually stuck on it, here where there's not only a visible spot, but it has some depth to it, which it's hard to see in a still picture, but there's actually a raised component of it, which we call a pigmented protuberance. Or these two is really easy, where there's active blood flow, where it's either oozing or squirting out at you. These all are high enough risk that you should think about doing something to decrease the risk of rebleeding before you take the scope out, okay? Adherent clots are the gray zone, where underneath that clot could be one of these guys, or it could be the low risk stigmata, or it could be one of the higher risk stigmata. So depending on where the clot is and lots of factors about the patient, we might ultimately decide. Oh, sure. Sorry, there was a question there in the chat that I'll go back to before we move along. I was saying that in patients who have a gastric ulcer, especially over 1 centimeter in size, they need to be brought back in 12 weeks, 8 to 12 weeks. But the idea being brought back in some sort of short interval after treatment with PPI therapy to assess and confirm healing. So that's the rough number there, is a centimeter in the stomach. H. pylori ulcers, so ulcers that ultimately are less than a centimeter, maybe in the duodenum, maybe in the stomach, but with confirmed H. pylori, they don't routinely need to be mandatorily covered again. So moving on to going back to what we were just talking about there, about the different stigmata there, with the scope, we're going to decide which needs to be treated and which not. And we'll talk about a couple of the tools we have to treat them. The algorithm, before I give you a little bit of a rundown on the different types of treatment. So those active bleeders, right? So oozing or squirting of blood with either with a visible or with that pigmented protuberance. While we're there with the scope, we got to do something about that. So endoscopic therapy, and then when we're done, they need to stay in the hospital to get an IV PPI. Again, old guidelines said bolus and infusion. That's the algorithm still comes from that, but some sort of IV PPI for 72 hours. So that hospital stay, once we have that endoscopic score, has already decided that that person's going to be in the hospital for at least 3 days. Clean-based ulcers, or that flat spot, they don't need anything. We could take the scope out. Maybe we biopsy if the ulcer was at all concerning looking. We biopsy for H. pylori, but that person, when the procedure is done, can be transitioned to an oral PPI, and theoretically, without knowing any of the logistics, be discharged from the hospital afterwards. Again, how often that happens, I think people are very complicated, so it's not always the case. The adherent clot really depends on if you're going to be brave to pull the clot off and see what's underneath it. If it's in a good spot, and what ultimately was under the clot will decide whether or not it falls into the endoscopic therapy arm or the no therapy arm. Briefly, you guys don't get to do too much of this stuff. This is what the fellows get to do and we get to do. But options for treatment. So we can inject epinephrine to stop or slow bleeding so we can see what we're doing. Epinephrine, both in 2012 and 2021, not recommended as monotherapy. It's only going to last a couple of seconds to a couple of minutes, and then anything will start bleeding again. But it's very good for slowing things down, stopping bleeding, so then we can take more definitive treatment. We can either crush and burn these blood vessels that are bleeding with thermal therapy or mechanical therapy. The current 2021 guidelines recommends thermal therapy for the fellows to know more so than mechanical therapy. So, and they did it, and they strongly suggest this, and they conditionally suggest mechanical therapy, but data has never shown head-to-head comparisons between the two. So afterwards, we've done the scope, we've talked to you about what we saw, but like I said, if they had a high-risk stigmata that needed to be treated, or if they were that adherent clot that we didn't think it was safe for us to take the clot off, so you have to kind of assume they have the worst case scenario underneath, those patients are going to be in the hospital for 72 hours with some form of an IV PPI. Drip versus boluses will be debated for forever, but IV PPI. If not, if they're the low risk stigmata, potentially can go home that day. Lots of caveats and many other things. There's some even data saying that in really small ulcers, could they even be on just an H2 blocker? All good thoughts. But the idea being is that they don't need to be stuck in the hospital for 3 days. For the people who have high risk stigmata, who spent 3 days in the hospital, they're going to go home on twice a day PPI for at least 2 weeks, and then can go down to once a day. That is low level quality evidence, but the idea being is that they might need more suppression than others. Most people will end up being on twice a day PPI until their repeat endoscopy if they have a big ulcer. But definitely those high risk lesions that spend 3 days in the hospital need to be on a BI PPI for at least 2 weeks, and usually longer, and this is a big reason we have to get them off of it. Do we have to always relook? Not necessarily in the hospital. Actually, most times, no. No need to routinely go back and just check and make sure everything's good. If they rebleed, rescoping should be the first option, unless there was a very specific recommendation or indication otherwise. So you had an ulcer, you stopped it, 2 days later, they're having more melena. It's not send them to IR or send them to surgery. It's look again with the scope and see if that vessel, a part of that vessel is still patent, if we can get rid of it. If after a second bleed, that's when, and we can't stop it, or they bleed a third time, that's when we should have our IR and surgery colleagues on ready to go. So they might be on board earlier than that, but that's when it'd be their time to shine. So how do we prevent it moving forward? So in our patient in this stem, we had multiple NSAID use. We could check their H. pylori status. We could decide what NSAIDs they need and maybe make a decision based off of what their underlying pathology is on what's the best type of NSAID to use, and then how can we help keep them on the medicines they need. So what do I mean by that, right? So if they're H. pylori, find it, treat it. Stool testing and breath testing in the hospital is, one, hard to get, and two, less consistent because of all the PPI use and they're actively bleeding. Antibody testing is reasonable if we're going to take the course to say that if you have an H. pylori positive antibody, we're just going to empirically treat you as if you are active H. pylori. Gold standard is biopsy. Even if you're on a PPI or not, we should be able to find it with that. So if you have some data suggest that PPI is if H. pylori is happening, eradicate it, confirm eradication, and that might be the only thing they need to do to not have ulcer bleeding anymore. If they're on an NSAID, decide which NSAID they're using. So not all NSAIDs are considered equal based on their risk of bleeding or their cardiovascular risk, right? And so if some people with bad joint disease, NSAIDs are the only things that allow them to be functional. And that doesn't, just because they have an ulcer bleed doesn't mean we basically get to say to them like, hey, sorry, just stop using your hands or your knees because I don't want you to ever have an ulcer bleed again. We have to be a little bit more creative than that. And so this table down here, which when you want to look at the slides at some point later on, but it kind of brings you through that, some NSAIDs are associated with some higher risk cardiac output conditions, and some are associated with more bleeding. So if the risk for a patient bleeding is high and they have a low overall cardiovascular risk, but they still need some sort of COX inhibition, using a COX-2 inhibitor and a PPI or misoprostol, will try to balance that risk benefit of at least getting some of their inflammation under control, but not letting them bleed again. Conversely, if their risk for bleeding is low, and because you got rid of their H. pylori, for example, and you're going to get rid of other unnecessary NSAIDs, trying to use the least effective dose is okay. They don't have to be banned from using NSAIDs for the rest of their life. This middle area here, the low dose aspirin, I think it's always good to understand why we prescribe that, right? And who is a primary versus a secondary prophylaxis. So, you know, in someone who's had a history of coronary artery disease, who's had an MI, that's secondary prevention, right? That's a much different category of patient than someone who has high blood pressure who's never had a coronary event. So if they have a bleed on their baby aspirin and have never had a cardiac history, maybe the benefits of primary prophylaxis for them is outweighed by their bleeding risk and we won't restart it. In someone who has multiple stents in their heart, that baby aspirin is really, really important. So we're going to do everything we can to keep them on an aspirin in addition to any other treatment that they would need, okay, like Plavix and so on. And if we never find a good reason for their ulcer, sometimes the safest thing to do is to keep them on a PPI indefinitely, or some data says an H2 blocker over. If you're having patients worried about the long-term risks of PPI, which is a different talk for a different day. But again, doing something to try to minimize that risk of bleeding in the long term. So again, if it's not just as simple as ulcer disease being the most common thing, some of the other things that we treat, so just inflammation can bleed, so treating the root cause of inflammation, these abnormal blood vessels like AVMs, which are seen in the small bowel, which we might go after with deep enteroscopy, can be treated with APC, argon plasma coagulation to burn them away, just to try to get rid of the big ones. There's limited treatments for things like cancers that are bleeding, because ultimately either we got to cut the cancer out or treat the cancer, but there's not much a PPI can heal in terms of that ulcer. We have some temporizing tools, sometimes embolizing the tumor to shrink it down will make it less likely to bleed. We have some different types of sprays that can stop immediate bleeding, but again, these are all just very limited and only buy us time as opposed to definitively stopping us. I'll pull down to the bottom just because I want to make sure we get to some of the other things in the talk, but one of the main ones that you never want to miss is when someone presents with like a little bit of bleeding, has a history of like an aortic aneurysm repair and has hardware in their aorta, and they had that small little bleed, otherwise look well, but then all of a sudden, you know, sooner than later, they're going to open up. And what they actually had to start was this aortic enteric fistula. And, you know, this sentinel bleed happens where they have like a big flash of bleeding, melena, bright red blood, and it seems to stop on its own. And that sort of is the canary in the coal mine before the next big bleed's about to happen. And so people who have had their aorta manipulated, have hardware in place in the aorta, if the history of a GI bleed is anywhere, if there's questions about GI bleeding, that's gotta, you have to have that in your head first and foremost. It doesn't mean that every person needs to get a CTA right away, but you need to be asking questions. You need to be really sure about what's their history of their aortic disease, what type of bleeding were they having, was it really a flash of bright red blood, was it melena, and so on, and have a low threshold to check those patients with a CTA, since and there's no role for endoscopic therapy in that. So you're going to have someone who you thought was more of an upper GI bleed and doing all the stuff we just talked about, and really what they needed to do was to have you know, a vascular surgeon ready to come and fix their aorta. That's what's going to ultimately cause the problem, is the root cause of the problem. Okay, so shifting gears a little bit for case 2, and now things can go a little bit faster since a lot of the resuscitation stuff all falls into that first one. We have a 62-year-old male, Hispanic male, multiple admissions for alcohol-induced pancreatitis and a history of arrest for DUIs, came in via EMS for hematemesis, reportedly bright red blood, dizziness and fatigue. Very, very symptomatic with minimal movement and had 2 black tarry bowel movements. He's actively drinking. His exam is significant for jaundice, sclerolicterus, spider angiomas, melena, and has melena on rectal exam. Labs are significant for an AST over an ALT 50 of 25. So AST is higher than ALT. Platelets are low at 65,000. Hemoglobin is 7 and the bilirubin is 8. So what jumps out at you here? Multiple alcohol-related issues with liver enzymes that look like either alcohol-related or cirrhosis, has a low platelet count, is throwing up bright red blood, and has a bilirubin at 8. Here you worry more that this is not only just an upper GI bleed because it's throwing up blood, but in the setting of liver disease. And the main thing you'd worry about here is VARICEAL bleeding. Virginia Hospital Center is all over the chat today. Kudos to you guys. So case 2, VARICEAL bleeding. So very common complication of portal hypertension. cirrhosis being the most common way we get portal hypertension. Lots of different ways to get cirrhosis. We won't go into all those things. There's one little caveat about different types of varices. Most of what we're talking about today is esophageal varices. There are gastric varices too. They're less common than esophageal varices. And gastric varices can also pop up in people who don't have cirrhosis, right? So if you had bad pancreatitis that obliterated your splenic vein, for example, you can get some isolated gastric varices that can bleed just as bad as our portal hypertensive esophageal varices. So esophageal varices versus non-esophageal, so gastric, duodenal, rectal, treatments are a little bit different because we have good tools for esophageal varices and we have less good tools for other types. Management of, this is again, management of acute bleeding. We're not talking about screening people for varices here, so that's totally different. So same initial recommendations, right? Find their vital signs, put them in the right bed in the hospital, resuscitate. However, also keep in mind that there's a sweet spot with variceal bleeding, right? The more blood and the more fluid and the more things we put in, the higher we make the portal pressure, the more likely things are to bleed and continue bleeding. So we want to resuscitate them to a point where it's safe to intervene, but not over-resuscitate them. We don't want to over-resuscitate anybody, to be honest with you, but definitely with liver patients, we're trying not to flood them with volume before we get them into endoscopy to treat them. Also remember, we're talking about this guy. He's a variceal bleed. We're gonna talk about variceal bleeding, but 40 to 50% of upper GI bleeding in all cirrhotics is peptic ulcer disease. It's AVMs. It's things that are non-varices. So IV access, keep them NPO, because variceal bleeding tends to have more hematemesis, especially large volume hematemesis. Securing the airway becomes a bigger deal. So intubating them to try to keep their airway safe and to keep them from aspirating before we can do the endoscopy. So big differences from non-variceal bleeding. So octreotide is the main medication we have, terlipressin for other indications in portal hypertension, but octreotide here in the hospital to help with splanchnic vasoconstriction and decrease portal venous flow. So this will help us drop portal pressure, which will hopefully help shrink those veins down, and then stop the bleeding before, or even slow down the bleeding so we can go in and intervene. This is continued for 3 to 5 days after endoscopic therapy. For patients with cirrhosis, you're going to give antibiotics, prophylaxis against SBP. This is not stopping the bleeding. It has nothing to do with the bleeding, but it has a mortality benefit, which is important for our patients. Also a very fun test question that they love to ask you. So of all the things I talked about today, antibiotics in a cirrhotic who's having a variceal bleed is one of the only interventions that has a confirmed documented mortality benefit, because SBP is so, spontaneous bacterial peritonitis can be so deadly. So they're going to be given ceftriaxone right out the gate, and they're going to do a 7-day course of that. So already your patient with a variceal bleed, as you think about discharge planning and all these things that we do to help keep the hospital flowing, this person's going to be here for 3 to 5, up to 5 days of their octreotide, and they're going to be getting at least 7 days of antibiotics. You can eventually switch those to oral, but they're going to be here for a while. Ideally here, these patients get an EGD within 6 hours, 6 to 12, depending on the paper you look for, but that's very different than our peptic ulcer bleeding patient, right? Where we said up to 48 hours could be considered urgent because of the nature of these varices and how fast they can bleed and how sick the liver patients can get. So here, the other benefit of scoping them sooner is that you can sort of thread the needle of resuscitating them enough where it's safe to do endoscopy, but not trying to bulk them up so that they can sort of settle out and end up getting more fluid than they need if we could go in and stop the bleeding and then limit how much transfusions, platelets, and other products they get overall. So when we go in with the scope, we can inject a sclerosing agent, or we can use these, most endoscopists now use these bands to grab the vein, the varix, and crush it at its base. And so now that blood flow is trapped. There's no more blood that can fill that varix. Some of it might bleed out into the lumen, but no more blood flow can get out into the lumen. Eventually that band falls off, the tissue falls off, and there's an ulcer there, and then that ulcer heals. But now that vein, that blood flow is rerouted through due to the portal hypertension, has been crushed down, and blood flow can't get back in there anymore. And so we stop the acute bleeding. There might be other varices that pop up. They might bleed again from others. They might bleed from our ulcers, but over time, in portal hypertensive patients, if we can get their portal pressure under control, we can crush these veins and get rid of their varices to hopefully minimize their risk of bleeding again. So what happens if endoscopy fails, right? So sometimes we're just not able to stop the bleeding. The varices are too big. There's too many of them. They're gastric varices, which don't have good endoscopic tools. At most centers, or really even internationally, there's not great endoscopic management of gastric varices. As a temporizing agent in the ICU, we have a special type of nasogastric tube that can go down with balloons. Minnesota tube is one name for it. But basically, it has a combination of balloons here where we inflate the esophageal balloon to push those varices down and tamponade them. Sometimes if the varices extend into the cardia, we can also use this gastric balloon to help crush where the veins start to fill up. So typically when we put this tube in, what we actually do is it goes in through the nose, it goes down to the stomach, and the first thing we do is we inflate the gastric balloon, and then we pull that tube back until we can't pull it anymore. That tells us that the balloon is stuck against the GE junction. So now the blood flow that's coming from the diverted blood from the liver, really, through what portal hypertension is causing, can't get into those varices anymore. So that hopefully decreases blood flow enough that the bleeding stops. If bleeding is still happening, we can then inflate that esophageal balloon to provide direct tamponade to the varices themselves. But usually just the inflation of the gastric balloon is enough. This tube, the Minnesota tube, again, is a time, it's to buy you time until you get them down to IR to get their tips. All right, so this is not something you're going to put this in and be like, oh, they're good, go to bed for the rest of the night. We'll check on them in morning rounds, right? Like, this is so that the bleeding can stop, so you can keep up with their transfusion requirements, so you can get them down to actually put in a transjugular intrahepatic portosystemic shunt or TIPS. Or we're actually going to bypass the liver, connecting the portal veins to the systemic venous return in hopes of now decreasing portal pressure drastically, so that way bleeding stops. There are downsides to that, right? And not every patient is a good candidate for TIPS. And so we won't get into all the specifics of that. It's a little bit more complicated, but just knowing that uncontrollable variceal bleeding, TIPS is one of the, and other types of shunts are sort of the emergent backup if endoscopic therapy fails. So for our non-esophageal varices, gastric varices, there's different locations here diagrammed over. So the GOV1s and 2s can sometimes be treated as if they're esophageal varices, if they're very close to the GE junction. So things like banding can work. Isolated gastric varices, not in continuity with esophageal varices, are a little bit more difficult to treat with less endoscopic options, as are small bowel varices and colonic varices, or people who have ostomies with stomal varices. Those are patients where if you're convinced that's what's bleeding, you're going to have a much lower threshold in those colonic, small bowel, isolated gastric varices to go to TIPS, because you know that your endoscopic tool isn't going to be effective, right? Oftentimes we work in tandem with the IR doctor, so we're going to take a look to confirm that's the diagnosis, but we're going to have them on board and ready to go sooner because we have a higher suspicion that it's going to be something the scope can't control. So after emergent care for especially esophageal variceal bleeding, let's say we scope them, we band them, they're doing their 3 to 5 days of octreotide, they're doing their antibiotics, they're going to need more endoscopies in the future after discharge, because it usually takes 2 to 3 sessions of bandings to fully eradicate the varices in the esophagus. Usually, again, we give them enough time for the ulcers on the veins to heal, so that way we can band them again if they're there. A beta blocker is another tool for either primary or secondary prophylaxis of bleeding. So in someone who's bled, though, they should not only have band ligation or eradication of the varices, they should also be put on a beta blocker, unless there's a contraindication, to decrease the likelihood of repeat bleeding after they leave the hospital. So the people we were talking about, there's some patients, if they're encephalopathic, if their MELD score is too high, TIPS is not necessarily recommended. So in the patients where we got the bleeding under control, so now this is not an emergency anymore, what can we do? And in some patients, doing TIPS, if they're going to be still a while away from getting their liver transplant, right, earlier rather than waiting for their next variceal bleed, is the right thing to do. So cirrhotics will often do poorly even if the EVD is successful. So after we stop the bleeding in the hospital, we might still send them down to TIPS. And these are in our child's PUB or with active bleeding. So they were bleeding, or our child's QC patients who we saw varices we were able to stop. They might be benefit from doing TIPS sooner rather than later. And we would be working with us, the transplant hepatologist, the IR doctors, to make that decision, because it's not one size fits all. Okay. So I don't want to keep you over too much. There'll be multiple times a year where we can talk about bleeding. So I think it's better to pause here after talking about a lot of the upper GI bleeding, which is where a lot of the nuance of treatment is. So I can answer some questions. The chiefs will have my slides. And so the last case is a case of diverticular bleeding that goes through a couple of the small changes about like, when do we do endoscopy? But really the takeaways are all the same in terms of resuscitation. The goal of endoscopy to help prognosticate what was the cause and what's the outlook moving forward. And then trying to reduce risk factors moving forward to keep them from bleeding.